Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, and welcome back to the MedEvidence podcast. I'm your host, Dr. Erich Schramm, sitting in for Dr. Michael Koren today. For those who don't know me, I'm a board-certified family physician and long-term clinical research investigator with the Encore Clinical Research Group. And I'm very excited to be here with my guest, Dr. Heather Luing. Dr. Luing is an excellent clinical psychiatrist, and I've had the pleasure to get to know Dr. Luing over the last 2 years. We share a clinical space and also an interest in clinical research. So welcome to the MedEvidence podcast, Dr. Luing.
Thank you, Dr. Schramm. It's so exciting to be here today.
Well, thank you. And we've got a very interesting topic to discuss, major depressive disorder. But before we do the deep dive into that, perhaps you could tell us a little bit about your background, tell us kind of where you grew up and how you ended up getting interested in psychiatry and specifically interventional psychiatry that you practice.
Okay, well, that's a big question. I'm a native Floridian, so I grew up in South Florida and studied microbiology as my undergraduate degree and then moved up to University of Florida. And I did my medical training there, so medical school, residency, and a fellowship in forensic psychiatry. So I'm now triple board certified in general and forensic psychiatry as well as addiction medicine. And I've done a lot of different things in my career. So I started in community mental health and worked there for quite a while. Did a little bit of time working as a medical director at a substance abuse treatment facility. And then I've done a lot of inpatient hospital work. And in 2017, I started my private practice.
Wow, that's very impressive. Going back to your training, tell me a little bit about you had a fellowship in forensic psychiatry. Okay, exactly what is that and what got you interested in that?
Forensic psychiatry is a subspecialty of psychiatry, so it really focuses on the areas where psychiatry and the law intersect. And there's quite a few of those when you think about it. There's criminal type work when people are being evaluated for sanity. And then there's a lot of questions that come up in civil cases that involve psychiatry. So a lot of it is acting as a consultant and really an educator to help people understand about psychiatry and mental wellness and health.
Right. And that's still an important part of your practice today.
It's a percentage of the work that I do. I do enjoy speaking and consulting and educating, and I spend a lot of time still with patients as well. So I do a little bit of everything.
Oh, that's terrific. And talking a little bit about your background, you actually were involved in teaching as residents at one time in the course of your training and your work at University of Florida.
Yeah, teaching has always been important to me. Right now, I work with psychiatry residents from the HCA Orange Park program. So I always have a third-year resident who rotates through my clinic, which has been a lot of fun. It keeps you on your toes.
Right. And full disclosure, when I do have opportunities to be in the office with you, I'm never up against coming to pick your brain on particular patients or a condition. So I think I often see you in that kind of teaching and support role. So that's really fantastic.
Well, I think medicine is a team sport, right? So it takes a lot of members of the team to make things work.
Wow. Well, so today we have a really interesting discussion on major depressive disorder. My background in family medicine sees a lot of depression. So we can talk a little bit about epidemiology. If you could work us through a little bit of major depressive disorder 101.
Yeah. I think it's so interesting in the U.S. that really the majority of depression is treated by primary care. So definitely the important front lines, and for a lot of patients, the only doctor or practitioner that they're going to see for their depression journey. Mm-hmm. So it's a kind of a rare patient that actually gets to us as psychiatrists. Depression in general is such an interesting condition, I think, partly because it's so common. Mm-hmm. So 1 in 5 Americans are going to deal with a major depressive disorder at some point in their life, which if you think about it, is a huge amount. Right. Probably all of us either have gone through depression ourselves or know somebody in our circle who has struggled with it. So it's very common. However, I've heard it referred to as the common cold of psychiatry. And certainly in its frequency, it is, but it's a common cold that could kill you. It has a fatality rate, right? And so it's a very serious condition. And besides the risk of suicide, it's a very disabling condition. So it's actually in the top 1 or 2 disabling conditions worldwide that keeps people not only from working occupationally, but functioning in their normal environment with relationships, with just day-to-day activities.
Wow. And really, that's a great reflection on the scope of the disease, the effect that it has on patients. And like you said, it's debilitating. And so maybe we could talk a little bit about, what are the kind of typical symptoms that a lot of people might be experiencing with depression?
Yeah, I think depression's interesting because when you ask an average layperson about what is depression, we all kind of have a little bit of an idea, right? We recognize depression in some degree when we see it, but I think we tend to under-recognize it. And so the DSM-5 is our diagnostic and statistical manual. It has a very clear definition of what depression is. So in order to meet the criteria for a major depressive disorder, you have to have a low mood and or anhedonia for at least 2 weeks, and that has to happen for at least most of the days. Now, anhedonia is that concept of lack of pleasure. So it's where you used to enjoy going to your son's baseball game, and you're still going, but you're not getting pleasure out of it anymore. It's not enjoyable to you. Right. And it's one of really the key diagnostic criterias of depression.
Wow. So you're there, but you're not really there.
Yeah.
You just feel like you're kind of going through the moves and yeah, I've seen a lot of patients like that. So it's really such a challenge. So with that, what you see other things being affected, sleep?
Yeah. So besides those 2 criteria, there's a list of other things that may be affected. And sleep is definitely one of those. Now, sleep and appetite are interesting is that for some people, they have less of them, right? Maybe they have a hard time sleeping. They're suffering from insomnia, or their appetite is just gone and they're losing a lot of weight. But for others, it really swings in the opposite direction. So we have people who have hypersomnia. They have a hard time getting out of bed. They spend many, many more hours sleeping than they should and kind of use it as an escape. And we also have a subset of patients who will overeat as something of their depression. So they may be gaining weight rather than losing weight. Right. Other things that we see commonly affected is energy. So a lot of times when you're depressed, you just don't have much energy or motivation. Mm-hmm. Concentration is one that I see a lot. And I have a lot of adult patients who contact me thinking maybe they have ADD or ADHD. They're having a hard time staying on task with their work. But the reality is a lot of times it's depression. So some of the symptoms of depression really can cross over to other psychiatric disorders, which can be confusing.
Mm-hmm. Boy, that really resonates to me as a family practice physician, because again, I'm kind of checking off the boxes for the patients that I see, and you've really, really nailed down the symptoms really, really accurately. So when you're seeing these patients, what kind of therapies do you have to offer these patients?
Yeah, I always think in a really holistic way. So the first thing I want to think about when somebody is dealing with depression is lifestyle, right? Are you getting enough sleep? Is your diet sufficient? Are you getting enough of some of the essential nutrients that we know the brain really needs to function at its best? Mm-hmm. What about exercise? So many people, neglect exercise, but it's one of our best antidepressants. Mm-hmm. And the really exciting things that the studies show is that it doesn't take really extreme exercise to get the mental health benefits. Even something very low, very moderate can be helpful. So I encourage patients, try walking around the block, take your dog out for a walk, take a bike ride, things like that can have a profound effect on mental health. So we always start with the basics. Mm-hmm. After we make those lifestyle adjustments, then the next thing I always think about is psychotherapy. Okay. Therapy is very safe. You're not going to hurt anyone with therapy. And for a lot of people, it can be beneficial. So that's the foundation we build on. For some people, that'll be enough. And then others are going to need a more biological way of treating depression. Mm-hmm. So traditionally, that's been our antidepressant medications.
Okay. And I guess, and each patient is different, obviously, to know, okay, when all those in a holistic approach, totally agree with, because I'm a holistic physician. But of course, when somebody might come in and maybe there's some red flags or a higher level of concern for a patient, then, obviously you have priorities that allow those patients to seek maybe more intensive or more appropriate treatments.
Absolutely. Absolutely. And the longer that I really specialize in depression treatment, the more I see depression as an emergency. So by taking a holistic approach, we certainly don't want to slow down more aggressive treatment if patient's depression is severe and warrants that. Mm-hmm. The quicker we can get a depressive episode under control, the better prognostically a patient is going to do. Mm-hmm. So we don't want to waste a lot of time trying treatments that don't work, or letting patients kind of get into the situation where they have a partially treated depression. And unfortunately, that's what I see really commonly is patients who maybe have been started on an antidepressant, or maybe they've tried some therapy along with it, but the symptoms haven't resolved. They're not in remission of their depression. It's just improved a bit, but they still have a lot of lingering symptoms. And so that's really what I want to work with in trying to get patients into full remission.
Wow. And thinking about, your experiences, not just in the clinic, but you actually have a good bit of hospital-based experience where you would obviously be working with a more acute and more severe patient population in terms of people that are having suicidal ideation or suicidal attempts. Is that right?
Yeah, absolutely. Suicidal ideations and attempts are one of the more severe and concerning symptoms of depression. Mm-hmm. We always want to be watching for those. And sometimes those are what brings patients to the hospital. And sometimes it's more a profound level of dysfunction. So patients with depression can even go into a catatonic state where they really just stop responding like we would kind of think of someone as responding, and might just sit immobile for a period of time or have really profound symptoms.
Right. And is there a concerted effort to try to make that transition for those hospitalized patients? Do they typically come back into your practice, or do they have to be referred out to other primary psychiatrists out there?
No, frequently we'll see this type of patient in our practice. My goal is to treat depression effectively from the beginning so patients ultimately don't have to have hospitalization. Hospitalization is kind of our last resort, right? Nobody likes to be in a psychiatric hospital. It's a challenging environment. And so we want to work to try to find an effective treatment as quickly as possible. So hopefully things don't get to that level. But if they do, absolutely, they would return to our practice, and we would do everything to keep them at their best state.
Well, I really love the continuity of care you offer, holistic approach, and I do actually get to see your patients, and I think you're doing a fantastic job. I'm like, that's why I say I feel like you're really outstanding in your field for what you're offering the patients. A really very, very holistic approach. So thank you for being there for that.
Yeah, absolutely.
So let's get back, if we can talk about, you're an interventional psychiatrist, and you've already alluded to that, obviously, you're comfortable with pharmaceutical approaches to treating patients with depression, but you're offering something else as an interventional psychiatrist. And in your our particular workspace, you offer TMS and the esketamine, which is the Spravato. So, which I find interesting because, again, I see these therapies being applied just about every day, and it's quite amazing. So can you tell us a little bit about some of those therapies?
Yeah, absolutely. And we can talk about antidepressants, which have been kind of the backbone of psychiatric treatment. But the reality is there's about a third of patients who those medications just haven't worked for. Mm-hmm. And traditionally, our oral antidepressants have targeted primarily serotonin, to a lesser extent norepinephrine and dopamine. And for some people, that can be a miracle. It can be really, really effective. For about a third of patients, it just doesn't work for them. And so we have, as a field, labeled that as a treatment-resistant depression. Now, I personally wonder if in the future we don't consider that more of a monoaminergic treatment-resistant depression, which is our serotonin system. But at this point, we call it TRD. And so the treatments that you mentioned are treatments for TRD, or treatment-resistant depression. So TMS is transcranial magnetic stimulation. It's an FDA-approved treatment that's been around for about 17 years at this point. Mm-hmm. So it's not new, but I think it's the best kept secret in psychiatry. We just don't have enough people who are really aware of it as a treatment option, as well as the efficacy that it provides these patients. what TMS does is it uses a small, high-powered magnet to provide a focal stimulation to a part of the brain that we know in depression tends to be hypoactive. And it's called the left dorsolateral prefrontal cortex. So it's right about here.
Okay.
And that's a part of the brain that if you do PET studies or functional MRIs in patients with depression, you'll see that part of the brain has kind of gone to sleep. It's just not doing its normal connections with other parts of the brain. By stimulating it with magnetic pulses, we can generate neuroplasticity. So we help make some new connections that ultimately help restore the brain to its natural functioning rather than artificially adding a chemical or something different to the brain. So that's a great treatment. The other kind of big advance we've had in the last 6 or 7 years in psychiatry is bringing in glutamate as a new neurotransmitter that we're modulating. And so Spravato or esketamine was our first FDA-approved way of getting that glutamatergic action for patients' depression. And that's been really a fantastic treatment for patients as well. We now also have an oral antidepressant that has glutamatergic activity that's available called Auvelity. So we're getting more and more advances and more options for patients, which is fantastic.
So in terms of the glutamate, are we looking at the possibility for neuroplasticity on that end, or is that just a different mechanism?
No, it's very similar, actually. So neuroplasticity is thought to be the endpoint that we're looking at. We kind of get there a little bit of a different way, but we're getting ultimately the same results in the brain.
Wow. So very, very interesting. And getting back to what you're saying, that we have had TMS for 17 years, but it really hasn't moved into the forefront. And as a practicing family physician for 20 years, I'd have to consider that I really wasn't fully aware of the capabilities until, again, that, I'd had opportunity to work with you and see what a profound difference it is for these patients. And it isn't just, this is a feel good. This is actually kind of a rewiring of the brain, which is quite a bit different and more sophisticated than what we've been using with our SSRIs that have been around for, I don't know.
Yeah, since the late 1980s, I think.
Yeah. I'd be like, wow. So it looks like there is this kind of ready to move into this kind of whole new technology. Hopefully these therapies will be becoming more accessible to patients, and especially in the primary care field and the family medicine field. I think, again, I feel that it's good to be educating and say, look, what are the options for patients once they've kind of they're reading their endpoint with their SSRI or similar. So that's terrific. I'd like to talk a little bit about you're a fellow clinical researcher, and would look forward to working with you as part of the Encore Clinical Research Group. But maybe you could tell us a little bit about your research background. What got you interested in doing clinical research?
Yeah, what got me interested in it is I'm always looking for cutting edge treatments, and I want my patients to really be able to assess those as early as possible, because for some patients, it is a life or death situation. It is something where they need access to that. So I got really interested in vagus nerve stimulation, which is another type of brain stimulation. We have ECT, which we haven't really talked about, but is kind of our older way of treating depression with a procedure. We have TMS. And now VNS as well. And the interesting thing is vagus nerve stimulation was actually approved at the end of my residency training. So we're talking almost 20 years ago at this point. So we've known it worked, but we didn't have a way of accessing it through insurance so that patients could actually afford it. So this trial came about called the Recover trial that LivaNova sponsored, that was really to show Medicare and CMS that VNS was something worth paying for, and that it was something that could save lives and really help patients with severe depression. So we had an opportunity to start getting involved in that trial, and that's how I got my introduction to clinical research.
Oh, very interesting. But I recall in your background, you had been involved doing, even in your undergrad, you'd been involved in research. So I
did some bench research. Yeah, absolutely. Back getting my chemistry degree. Yeah, it was pretty fun. Actually, ended up after when I was in medical school, one of the compounds that I developed actually found promise and ended up in a publication. So that was kind of fun, but very different from what I do now with phase 3 and phase 4 trials working with patients.
Right. But certainly equally, if not more important, because you're the kind of where the rubber hits the road, right? This is
every stage of research so important. Wonderful. Otherwise, we wouldn't have any options for treating any disease.
So you have treated the VNS patients with the vagal nerve stimulator. You've treated TMS patients. Do you see any similarities? How would you compare and contrast what you're seeing for patients with those therapies?
TMS is a non-invasive treatment, so it's simply a matter of kind of sitting in a recliner chair and having a magnet placed against your head. So very easy for patients. VNS is a little bit more of a commitment in that you have to have a procedure to implant a device under your collarbone. It's a minor procedure, certainly not a big surgery, but it is a bit more of a commitment, I think, from that standpoint. Now, the interesting thing about this VNS trial is a lot of patients had already failed other treatments, including TMS and esketamine.
Okay.
So a really severe group of patients as far as resistance, and we've seen really good effects. So I think VNS, we know it works from those original trials where it was FDA approved. We just haven't had a chance to really utilize it. So I think, all of these treatments for the right individual have a lot of promise. And it's really a matter of kind of navigating those risks and benefits and determining what's the right fit for you as a patient.
That's a great point to make. And ultimately, as researchers, we start thinking to ourselves, gee, wouldn't it be nice if we could find a way to compare, do a head-to-head, TMS, vagal nerve stimulation. It would take a lot of work, to try to how we could figure out how to make a placebo arm in that. But getting back to your interest in clinical research and cutting-edge technology, and it really resonates. So that's really cool. So let's maybe talk a little bit about kind of the newer pharmaceutical options out there now, and I think we're looking at a study that's going to come up looking at a particular compound. So maybe you could tell us a little bit about that.
Yeah. So we first discovered the first antidepressants by accident. It was serendipitous, right? These were patients who were being treated for tuberculosis. And what they found is that when they were given a certain medication, they had improvement in their mood symptoms. And so that's kind of where we got this idea that serotonin was the answer to treating depression. And we have run with that as a field for 40 years. Right. The reality is now we have learned that may be kind of a backdoor way of treating depression, because the reality is I can deplete someone completely of serotonin by removing an essential amino acid from their diet, and they don't get depressed. So we know it's not just a serotonin deficiency that causes depression. We also know if we treat somebody with a serotonergic agent, it takes 6 to 8 weeks for most patients to have a clinical response. Right. That's very slow. And what we see is those serotonin levels actually correct much before we see the clinical improvement. So that's led us as a field to think, well, what other things could we modulate to help get a quicker and more effective improvement of depression symptoms? Right. So glutamate has kind of been the first that's come to fruition, and we're still trying to figure out other ways to affect the glutamatergic system. And, glutamate and GABA are they go hand in hand, right? It's the brakes and the gas pedal, kind of, if you think about it.
Okay.
So there's certainly, certainly GABA agents that are being investigated right now. One area that I'm particularly interested in is the kappa opioid system. Okay. So when we think of opiates, the first thing people think is bad, right? You think opiates are something you're artificially taking into your system and causing our opiate crisis. But the reality is we have an endogenous opioid system. So opioid system within us is natural, right? We have to figure out how can we influence that system, because it seems to have a lot of effect on mood. So the particular study that I think you're referring to is the coastal study looking at navacaprant. And that's a new novel agent that we think has antidepressant effects. And it is a kappa opioid antagonist. So that's a study that I've been taking part in recently as a PI. And we're hoping that we'll find new ways to positively affect depressive symptoms. That's
wonderful. And getting back to understanding from a primary care standpoint and talking about some of the problems associated with serotonin-based medications. We talked a little bit about that, but we talked about anhedonia as a not uncommon circumstance where patients on antidepressants, but also the potential for sexual side effects, possibly weight gain. So there are certainly barriers that can come up with compliance for those. And you mentioned that there's a high rate for recurrence. And so this sounds like this is a very promising potential avenue for treatment.
Yeah, you've highlighted a lot of reasons people don't like their traditional antidepressants, right? If you're depressed, getting fat and having problems with your sexual life does nothing to improve your depressive symptoms. So those are never popular. The other challenge with anhedonia and SSRIs is a lot of patients just don't get an improvement in that anhedonic tone or features that they have. So what that means, I kind of describe it to patients, is you go through life looking at things in black and white. Right. You don't really just see life in technicolor that the rest of us do. And so we want to try to find medicines that are better at targeting that anhedonia because it really is a disabling and disruptive symptom in patients' lives.
So this is a receptor antagonist. So you are affecting neurotransmitters in that sense. But this wouldn't necessarily be considered something that would have neuroplasticity, or does that?
It potentially could. I think, that's the exciting thing about clinical research is we're learning, right? We're learning how are things going to ultimately react in the brain. But I would highlight one of the nice things about being an antagonist is, you're not influencing the opioid system in a negative way like we've been used to with opioid medications. So we're not causing any kind of reward. And because of that, they're not controlled medications.
Yeah. And I think that's a really good, important point to make because it is, I think for a lot of people would think, okay, well, again, familiar with what opioids do for the opioid receptor in patients who have those, who get that. But, gosh, here's this thing that is regulating a lot of our mood and our pleasure centers and reward centers. So, and here we are, back to research and that cutting edge, looking at that. So this is, I think, a terrific opportunity. And, if you think about now, compared to, 20, 30 years ago, now we're really being able to offer patients a wide variety of options to consider, whether it's DMS or what's going to be esketamine. And now we look at glutamate and the KORA opioid receptor antagonist. So, and we were talking earlier before because, we've both been in research for a long time, and there was a period where it seemed like there wasn't a lot of new things coming down the pike. And, we're like, gosh, now we can see that there's actually quite a bit opening up here.
Yeah, it was so depressing as a new graduate coming out of residency to see companies closing their CNS divisions and knowing that, I was going to face a career treating patients without getting new advances in the ways that I would do that. And it becomes very discouraging when you have a patient in front of you and you know that after the second antidepressant failure, that patient has about a 14% chance of having a response from one of our traditional antidepressants being used third line. And we learned that from the STAR-D trial. And we've known that for a long time, but we haven't had a whole lot of alternatives. So now we're at a point in time where it's so exciting that we have many alternatives. And I think what we have now is just the tip of the iceberg. I think there's a lot of exciting things to come.
Wow. You're saying everything I want to hear right now. So, well, terrific, Heather. I thank you so much for giving us your time. Is there anything else you'd like to add or any question I should have asked that I didn't ask you?
I think the biggest thing is just reminding everyone that depression's a treatable disease and that people don't have to live with these disabling symptoms, that there are effective and safe treatments out there that are FDA approved, right? They have that clinical research behind, which gives us information on efficacy and safety. And most of the time they're covered by insurance. So they're affordable and accessible. So there's no reason to accept depression as a reality that you have to endure.
I love that. And also I'll add that, we're kind of one of our themes here in this clinical research office to let patients know that research is a very reasonable care option. We can't guarantee whether you're going to get on the study medication or placebo, but we know that patients just coming into the office, get a level of care that will have a positive impact on their health. So again, I think that's a point we like to make here. But
absolutely. We were kind of talking before the show too about some of the challenge of depression trials is a placebo response. And,
right.
The reality as a psychiatrist, taking off my clinical research hat, placebos are fine, right? We just want patients to feel better. So if somebody comes into a clinical trial and feels better, no matter how, that's a win for them as an individual. Mm-hmm. I think that, something to think about with research is you're contributing to the future of science as well. So if you have a history of depression, you may have family members that may have depression in the future, and helping find better treatments is just helping other people as well as yourself.
Wow. Great closing point, and thank you so much. And maybe we'll do another episode. We'll pick a topic, and maybe we can talk again on maybe anxiety or sleep. So maybe we can do that in the future.
Absolutely, it's my pleasure being here today.
My pleasure seeing you again, Heather. Take care.
Bye-bye.
Bye.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.